Hello, listener, and welcome back to the Rural American Surgeon Podcast. Today's guest is phenomenal, and she's a military surgeon. I know many of you are military as well. She has quite a story to tell, mainly about autonomy, how rural practice can enable this, and then we went into an excellent how I do it. So this is going to be the first of a two-part series with Dr. Amy Vertrees from the Boss Business of Surgery series, as she's known in ACS circles and other places. So without further ado, let's get into the show. Welcome back, listener, to the Rural American Surgeon Podcast. I'm your host, Dr. Randy Lehman, and I'm very honored to have with me today Dr. Amy Vertrees. Thanks for coming on the show, Dr. Vertrees.
Thank you so much for having me. Such an honor.
Yeah. So let's lead into a little background about you. If you could tell us your background, training, and then what your past practices and current practices look like.
Sure. So I went to the military medical school, Uniformed Services University of the Health Sciences. A lot of people haven't heard of it. It's the only military medical school we have. It's in Bethesda, Maryland, and you become a commissioned officer in the military. So I commissioned into the Army in 2000 and went to military medical school from 2000 to 2004. I was in the DC area. I ended up doing general surgery residency at Walter Reed. I was asked to stay on as staff and deployed 3 times as an Army surgeon. And after I finished my residency and my payback for the military, I got an employed job for 3 years. And then after 3 years, when my contract was up, I started a private practice. So I'm currently in private practice that was initially meant to be a cute little solo practice. And now I've got 5 surgeons, 2 nurse practitioners, and we cover 3 hospitals.
Yeah, and it's very interesting. We have some similarities in that regard because I went to hang up my shingle. That was my dream, to go back to my hometown and just be independent solo practice general surgeon. But then I've identified these needs in rural surgery at the critical access hospital, sort of in a regional area. And it's just been a kind of development of a deeper understanding of what the needs are of each place. And I feel like you guys are kind of doing the same thing. And so your practice is growing like in a similar way. Maybe we can dig into some of the things that you've learned, about that. Maybe I'll just ask one question. What's been the hardest part of doing what you've done?
Specifically private practice, it's interesting because it unravels over time. So it's funny because there's a neurosurgeon that's sharing space with us now, and he's early in the private practice thing. And I'm seeing some of the struggles I had early on that I don't have anymore. So when you first start a private practice, the first thing is overwhelm. It's where on earth do I start? What am I supposed to do? And there's so much that we don't know because there's so much of the business of surgery that we're just not taught. So the first is overwhelm. How do I do all the things and not make mistakes? And then it's, how do I grow this practice? How do I work the math problem that is making sure my incomes are more than my expenses and make sure my tax burden isn't too high? And then it's just the same things that all of us have, is how do I manage my time and how do I work and ensure that the patients are well taken care of and that my time is managed well. But with private practice, all the things that frustrate you as an employed surgeon are now your job. So all the administrative things that bother you and the people holding you accountable for things, and also the structure, that now becomes your job, which is great when you feel like you want to do it, but it can be a little overwhelming of trying to find out, how do you influence the people around you? How do you pick the right people? How do you make sure that everyone does what they're supposed to do? So you have to really understand other people's jobs as well, and how do you inspire them to be great at their job and want to stay? So those are, I think, probably the biggest challenges.
Yeah. And why bother? I mean, what's been the best part about it? If somebody else was considering, you were going to say, yeah, you should, this would be like the number one reason.
Yeah, employed surgery is not like the worst thing in the world. If you're at a place where it's managed well and there's always going to be some headaches, it's not a terrible thing to be at because of the stability and you don't have to worry about a lot of things. In my particular case, at the end of my employed contract, I thought it was about the money, so I negotiated a huge raise. And then 3 months later, it was clear as a bell. I would be complaining of the same things for the next 15 years and nothing was going to change. So for me, I couldn't make any changes and I couldn't evolve the clinic. To give you one example, this was a mind-blowing day. We don't have voicemail on our our phone when I was in the clinic. And I said, why don't we have a voicemail? It's like if someone needs to leave a message. And like they said, I don't want to give the impression that we're going to be answering it. And so when you have is what is run in a way of like, I mean, what are we doing here? I just felt like the clinic represented me. And I wanted to run the clinic in a certain way. I wanted my patients to have a certain kind of experience. And I was running into the constraints of the fact that, patients couldn't leave a message and they were given slots that I couldn't necessarily adjust. And the people, support staff weren't really helping me. Now, I discovered over time that some of the was things that I could change. So I think now with the skills that I've learned over time, I probably could influence a job a little bit more than I could have before. But there's certainly some constraints of just like, this is the way it is. And if you're under a difficult manager or a difficult administrative, hierarchy, then you may be really frustrated in your job. And I think that's really where a lot of people get dissatisfied is the people that they encounter.
Got it. Yeah. So that's basically the control and the autonomy and your micro environment and all those things. I tend to agree with those things. So thanks for bringing it out. Mm-hmm. So now that you're practicing, what's the size? The next question on the show is why is rural surgery special to you? But I want to know what the size is of the 3 places that you guys are practicing now. And are you personally privileged at all 3 sites?
Yes, I'm privileged at all 3 sites. And how it's evolved was when I left the military, we had the privilege of being trained to deploy and do all the things. So, for example, my first deployment, I was doing thoracotomies, neck explorations, complex abdominal surgery, including, dealing with the pancreas, the kidney, I managed a bladder injury that was complex. So we were trained to manage a lot of things. And I really wanted to have a broad-based practice. So luckily we had a rotation that really spoke to me, and it was a community hospital initially. So to have the full breadth of things that a general surgeon could do, so maybe not as many specialists, and do a lot of things to have a very varied practice, but still have some support. So that was initially the hospital that I chose. After leaving the military was a community hospital, 250-bed, non-for-profit hospital, and really enjoyed it. I really enjoyed the OR and the people. It was a perfect size, I thought, initially, of being able to do some big things, have some support, but so it was a good balance. Now, over time, over the last year and a half, we started realizing that there's 2 hospitals nearby. Now, these I think are billed as 90 beds, but that includes like some of your swing beds, your rehab beds, things like that. Practically, one of them has 3 ORs, and I think the other one has 5. And so a smaller hospital, they both have very small ICUs that don't quite have the same level of ICU of other places. So as far as rural surgery goes, I think they're a little bit larger. Now, I think the biggest challenge with these rural surgery hospitals is how do you fit the right surgeon at this place? So you have the one person who could do it all, and it could fulfill like a full-time surgeon, probably a little bit more, but they would not necessarily have coverage. And so what we found that we could offer, which allowed our practice to expand, is to say, we have one full-time surgeon for you, but we now have a backup of multiple surgeons behind us that can help circulate the call to make sure your call is always covered, to make sure that we can have some of these younger surgeons who may not be as experienced. So we can do more broad things with confidence, with good quality. And also the other side. So I think in these hospitals, if you get one person, you're going to get the young person who maybe can get in over their head, and that can actually end your career if you're not careful. Mm-hmm. Or older person who's on their way to retirement. So I think some of these communities run the risk of having that particular kind of surgeon. What we wanted was to have, a surgeon there that had a bit of a passion for rural surgery, which we have in both of those places now, the other 2 hospitals. And I provide support as the senior surgeon. So they book days of more complex things to where I could come see them. And all of them are within driving distance of my hospital. So I'm always willing to come into some of the more complex cases. So essentially what we have is a hybrid of younger surgeons and a senior surgeon who are managing all the problems. And we call it the zone defense.
Yeah, no, I love that. And it actually is take a moment to talk about what I have going on in Indiana, because I was in 4, now I'm in 3 hospitals. I'm kind of trying to get the alignment right for what I'm trying to do. And I have some very interesting developments where we're probably going to add more of like a hub hospital.
Yeah.
And that'll be the bigger place that has a real ICU, has inpatient cardiology, dialysis, things like that you can, because I'm running into issues at all 3 hospitals that you're talking about. Do they all have 24/7 call coverage?
They all have 24/7 call.
Okay, because all 3 hospitals that I have do not. So I'm in these hospitals are all critical access, 25 beds or less, but their real average daily census might be more like 5 to 10 in the whole hospital. And one place has 4 ORs, but I mean, we never use more than 1, and they only have anesthesia on select days and things. So it's a very different, and even the hub model for me is probably like the size of one of your smaller hospitals.
Yeah, like beds and staffing, completely different number.
Correct. Yeah, that's true. So anyway, I guess what I'm doing now is potentially building this hub model. And even with the 3 places, like I currently can't meet the demand. And I've hired a surgeon this year, my first surgeon hire. That was my big goal for 2025. And I've been reviewing, my goals because it's beginning of the year. And I did it. I can't believe it. And I look back and think about all the different surgeons that I talked to. And I had on my goal list for the next month, get contracts signed with XYZ surgeon several times that are surgeons that do not work for me. Okay. And then the right person came at the right time and it was obvious and we moved forward. I also hired another APP for wound care and yeah, it's a growing group, but I'm going to plug out there right now for myself that I need more surgeons, and I don't need them right this second, but I'm really very likely going to need probably 2. And I have myself, and now I'm 5.5 years out. And then I hired an experienced surgeon who has like maybe 15 or 20 years of experience. Very good mentor. And I'm looking I would look for someone with experience, but I would also look for somebody that was out of training. And the timeline of maybe a couple years, I signed my contract is actually in second year. December, my second year, for 3.5 years in advance. And I don't think a lot of people look that far in advance, but if that's something that you're interested in, then I'll tell you, go to the ruralamericansurgeon.com and just submit your information there on the contact page. And that email then comes to me. And I would love to hear from you and talk. And I would love for you to come visit me in Indiana. And even if it doesn't work out, I'd be happy to advise you about, places that may be right for you and let you kind of have my network and my advice, especially if it's somebody that's just, is another colleague, another general surgeon that's looking for the right thing for them. So sorry to stop and make a plug. But that's what I have going on.
Get jobs. I didn't advertise any of my jobs except for in networks that I had.
Yes. Perfect. So, and you have quite the network, and we'll talk about that in a minute. So that's a teaser. But before we do that, so now we understand what basically rural surgery means to you, like what kind of hospital you're in. So why is it special, rural surgery?
It still stretches like all the things that you think you're capable of doing. So I think the main problem that we have with training these days is this idea that you have to be fellowship trained to do certain things and that you can't do these things. And the more you tell people that they're going to actually follow that, like, oh, I can't do, rectal surgery because I'm not a colorectal surgeon. I can't do exactly. So, it's all anatomy exposure, understanding the risks, the benefits, and the tips and tricks. So as a surgeon, we can do more things. So I like the idea that there are areas that both allow us to do that, but actually really need us to do that. So it was interesting. I talked to one of the CEOs of one of the hospitals here, and he had this idea that this hospital was going to grow into basically like a mini Knoxville, like a mini thing. He's like, we're going to have colorectal surgeons, a cardiothoracic, and this and that. And I said, you're really missing the point of what this hospital has to offer, which is, broad-based, easier access than, like going to some of these places up north where there's difficulty. But, to build something of that size to keep the people satisfied, like everyone really needs a certain amount of volume to be able to do these things. And so it's just interesting how there's different personalities for hospitals. So I guess my point is that we have our own desires, what we think we are capable of doing and want to do. And there are different personalities for hospitals out there. And so finding the right personality that fits what you want to do and the personality of the hospital that doesn't have an identity crisis, is I think really where people will be more successful.
Yeah, I was listening to something recently, just what you're talking about, which is, it was a hospital administrator talking about success that they had in their area. And basically what they were saying is, don't try to be the big academic center or the big tertiary center. Hospital, they lose their identity is perfect. So figure out what is needed in your community and do that very well. The 80-20 rule or whatever, the 80-90% of the things, capture those and do them very well, meet people at their point of need. Understand that if you build all of these other service lines that are going to end up being low volume, it's going to drag your revenue down. So find the high volume things where you can meet the most need for the most people. And then you're going to have a huge platform, an actually profitable platform underneath you. Let's move into the next part of the show that's called the How I Do It. Yeah. And we're talking about volume and whatnot. We're going to talk about laparoscopic and robotic inguinal hernia today. So preparing for this, there's 600,000 inguinal hernia repairs done in the United States per year. Do you have a number in your head of how many practicing general surgeons are in the United States?
I feel like I've heard that number before, but I'm not 100% sure.
So I looked it up, but I'm coming up with differing numbers.
I knew there's 150 general surgeons in the Army, but that doesn't help you much.
If we knew how many inguinal hernias they were doing, but there's 34,000 certified by ABS. So then the question is, how many of those are practicing as general surgeons, or are they peeling off into other subspecialties? And there's other surgeons that are maybe not certified by ABS, also maybe still practicing as general surgeons. So I came up with between 17 and 40,000 total general surgeons in the United States when I was looking. And I kind of feel like it's a number less than 34 that are actually, practicing general surgeons, but it's not going to be less than 17. So shall we make an assumption that there's 20,000 practicing general surgeons?
Seems reasonable. I think the only other number I know of is there's 90,000 members of the American College of Surgeons, but that's lots of specialties across the world. So,
yeah, exactly. So say there's 600,000 inguinal hernias and 20,000 surgeons doing them. That would be 30 per year. And how does that number strike you? Because at first blush, it seems kind of low to me. But then I start thinking about, well, I say I do inguinal hernias every week, but do I really? What do you think?
I can tell you, I keep track of my case log, and the number one case, which has been published for most general surgeons, number one case is lap chole, or robotic chole, or whatever, cholecystectomy. So I do probably about 40 hernias a year. And I do
inguinal
about
hernias.
70 gallbladders a year.
You're talking about inguinal or lingual and ventral together?
That would be inguinal and ventral together.
And if you do a bilateral, does that count as 2 or 1?
I usually count them as 1. I mean, I think you could probably argue it's 2, but
you definitely have twice as much recurrence risk.
Oh, yeah. I mean, that has always been, kind of a challenge. Same is true for mastectomies. Do you count that as 1 or 2? So I usually just keep it simple. When I keep my case log, I just write the patient name, what their case was, and I just call it whatever that is.
Yeah. I run into the same issues myself. So we're kind of in a range. Maybe there's like 30 inguinal hernias, that might be over the average. Maybe there's actually 25,000 general surgeons or whatever, and it kind of jives with what you're doing. So you're kind of middle numbers because you peel out the ventral hernias, and then you're left with your inguinals, and maybe that counts bilateral or not. But gives you an idea. It's not like hundreds and hundreds necessarily. Now, I trained with some people that were really training on TEP, inguinal hernia repair, like in the cutting edge of that whole kind of period of time. And several of them had done over 1,000 TEP inguinal hernia repairs. My guess is they're counting both sides. But then that's over a couple decades to generate that. So it's still kind of in a heavy referral center where somebody's like the expert on that, still only maybe doing one or two a week, you know. So now we have the first part out of the way, which is the demographics or whatever you call it, incidence and prevalence. I want to talk about exactly how you do it. So how do you decide? Do you do open inguinal hernias as well, I assume?
Yeah, I kind of straddle the whole open to laparoscopic to robotic. So I've done all three, and I feel comfortable with all three.
Yeah. And like in the past year, have you done all three?
The past year, I actually haven't done any open inguinals. Those I tend to be if, the reason why is I think that the laparoscopic robotic repair covers the, femoral space. And have found so many occult femoral hernias and things like that I prefer a minimally invasive approach just for coverage of that area, and also for postoperative pain and decreasing the risk of activity limitations afterwards. So I don't think the open inguinal hernia repair is that bad of a case, but I feel like it's not as necessary majority of the time. I have done it in the emergency setting. I did one probably maybe 2-3 years ago where ended up having like a sigmoid colon perforation within an inguinal area, and ended up doing that open, and I used a biologic mesh rather than a wide pore. I think these days you could probably use a wide pore mesh. And so I usually do those. It's nice to have that skill set. It's nice to have the ability to do it, but it's not my preferred repair.
Yeah, sure. So, and you're basically of the camp then that has, which there's camps of people that says, pick the one that you like, kind of stick with it, and then and then minimally invasive on all of them is appropriate. Of course, if you're answering a textbook question for your boards, I would say that the time where laparoscopic repair would be strongly preferred would be two scenarios. One would be if you have a bilateral inguinal hernia, and number two would be if you have a recurrence after an open repair. Would you agree? Like generally, that's
and third would be female because
right
the higher risk of femoral.
Yeah, and now that's actually on guidelines, which has happened even since I came out of residency. And let me tell you about a quick case that I did where I think that you need to take everything with a grain of salt. And this is exposing my failure, okay? Shortly after those actual guidelines were released that say laparoscopic is preferred for a female, I had a patient, neighbor, lives like 2-3 miles from me, in my small town. When I say 2-3 miles from me, I'm talking the house I grew up in, where I've moved back to, where I'm raising my Highland cows, and I'm not going anywhere. I'm not a transient surgeon, like from somewhere, and I've got 5 years to burn left. It really, like that kind of practice, your complications, I think, bother you. People talk about surgeon graveyard and stuff like that, no matter who it is, just because they're another human being. But the other thing about rural practice is you're going to see these people like in the store and at the county fair, and it matters. So anyway, this wonderful lady, she came in shortly after and specifically to find me, specifically knew me, and she had a little marble, inguinal hernia, reducible, pops right in and out, is about, the marble is probably about 2.5 centimeters. She's skinny. She's healthy. She had a previous, maybe 10 years prior, Nissen gone wrong, and had a duodenal perforation afterwards and had
Oh
to be
my.
taken back to the operating room and had a laparotomy and got it repaired. And then she's back, and everything. So here she is, thin, healthy, tiny little thing. The guidelines had just come out. Almost a stem to stern laparotomy. What do you do?
In that particular case, I would still try a minimally invasive approach, whether laparoscopic or robotic. Either way, probably the challenge is going to be getting ports in and lysis of adhesions. So right. In that particular case, being a female, I would probably still try to do that minimally invasive. Just I'd probably book it for a longer time because I imagine lysis of adhesions may be right. a challenge. So, and I think there have been lots of things like, what are the contraindications that maybe not be contraindications? So, big X-lap incision may be one of them. Other things we think about, but to be aware of are things like, prostate surgery and things like that, things to be aware of. So I don't think there's huge contraindications for a minimally invasive approach. But in that particular case, I think open probably would have been fine too. If her main complaint is a hernia that you're staring in the face, that's helpful. But I think it does potentially put her at risk for femoral hernia. But of course, that's not the majority of hernias. It's going to be inguinal still.
Yeah, I mean, it's so obvious it's not a femoral, because of where it's at on the exam. I mean, there you could be duped, but you're not going to be in this situation. It's up on the abdominal wall. So anyway, I think it's a relative contraindication to do surgery, but it's relative and you have to make your call. And I think that's the same decision that I made. But if I had it to do over again, I wouldn't. And the other question, what if you got in and it was just like crazy dense adhesions everywhere? Would you ever, I have not really converted. I've converted some types of laparoscopic surgery to open, but I haven't converted very many hernia operations to open. Usually I can get it done, but what level of density of adhesions would make you convert to an open inguinal hernia repair after you place your first port?
That's a good question. I think most of the time, I would probably just do it and cry about it, but that's about it.
So that's what I did. And I completed the inguinal hernia repair. And I don't remember how many days, maybe 5 or 6 days later, she came back with a delayed enterotomy. Just belly full of succus and super sick and fever and white count through the roof. And then presented to a critical access hospital where I didn't have a call team and I didn't have an ICU and wasn't the place where I had actually performed that outpatient operation anyway. And so I talked to her about, well, we can transfer you over to this other critical access hospital where I do have a call team and I could take you back and wash you out and fix the problem and potentially remove your mesh. And, but the reality is now you're sick enough and you're septic that you have a very bad problem. And so this is the big challenge for me right now, like where I'm at. So you're out here, you're doing the best you can. And then something like this happens. And so I ended up transferring her to another hospital where another surgeon managed her complication, which is the hard part for me right now and why I'm looking more into the hub and spoke model and finding myself at another place where I can at least handle at least my own complications on a regular basis. Because even though like I have these two critical access hospitals, one has 24/7 general surgery. When I take a patient over there, they're always like, this is a lateral move. This is not an up. And I'm like, no, it is, because they have a call team and we don't have it at this hospital. But then the CRNAs at the other hospital are like, we're not on call for this other hospital. We're on call for our hospital. So then I was like instructing patients, if you have a complication, go to this ER because that's they'll take care of you out of the ER, but they don't want to transfer. And then the anesthesiologist trying to block halfway through. It's just a complicated mess. So anyway, the patient goes and gets a washout and the laparoscopic mesh removed. And then I think might have had a temporary closure and then comes back and gets closed and then later gets repaired by an open technique. And that's just a shambles, but it can happen. So I don't know what kind of, risk I put myself in to vulnerably put myself out here on a show like this. I'm not really too worried about it. First off, I don't think she's going to sue me. And if she does, I feel terrible about it. And everything that I said is fine if it's discovered and put on the stand, because that's exactly how it happened.
I have a
go
rule
ahead.
when it comes to that, stuff like that. When it comes to a complication, or really, honestly, anything, there is no role in going back in time and making yourself wrong, because you made the best decision you had with the information that you were given. So to go back in time and say, I should have done a different operation, that's not necessarily true. It's entirely possible that you could have fixed an inguinal. She presented with perforation from a femoral hernia, just as likely. So we just don't exactly know. But going back in time, I always tell people the only purpose in going back in time and going into the future is to go and give yourself some information and make a decision today. So like right now, you can't change the decisions that you made, and you didn't make wrong decisions. It's just what happened after the decision you made. Didn't make the decision wrong.
Yeah. So I would agree, except that when you're talking at M&M as a resident or as a attending surgeon,
with new
I think it's
information,
very important to never say, I would do everything exactly the same way again, because that is hubris, and you're talking about a complication. There's got to be, you have to come up with something at every M&M.
That's judging yourself with new information. So that is the part that I think that we have to be careful about, is going back in time to say, I see the decision, what was I missing, is completely different than saying, I would do everything the same, because we had that information at the time. Now, going back in time, we now have new information. And of course, we would make a different decision. It doesn't change the fact we didn't necessarily have that information at the time. It's a very big difference.
Yep. We're saying the same thing. So the other thing that I would like to say before we get started on how exactly you do the lap cases is, in my practice, if I have a man with a unilateral initial inguinal hernia, my practice is to do open first. And my personal recurrence rate is lower with open than it is with laparoscopic. And although there's studies that have been powered such that they say there's no difference in recurrence rate, usually in the studies, when you look at the actual raw data, the laparoscopic does have a higher recurrence rate than an open. They're both low single digits. They're both lower than the maybe 20 to 25% of just a tension, Bassini or McVeigh non-mesh repair. So the big difference is you got to do a mesh repair in 2025 to decrease the risk down to low single digits. But I do think it's a little bit lower recurrence rate with an open repair. And I know personally for me, it has been. Even some of these giant, and especially if they're giant inguinal scrotals, like how you're going to do that laparoscopically and not have a huge, you're going to have issues with seroma, hematoma, no matter what. But for me to reduce it feels a lot safer and better. So just saying, that's my practice. But not right or wrong to plan to go laparoscopic on everybody too. So any thoughts about that before we dive in?
I think the main thing is what you got training in. And this is where what we mentioned before is the best repair is the one that you can confidently do. And I don't believe that a lot of people are confident with an open inguinal hernia repair. I was lucky in my residency, we had plenty of training on that. And there were several people who really believed in open inguinal hernia repairs, but it is a challenge. And I think one of my chief residents said it best. He said, open inguinal hernias are the one that you let the intern do, but only the chief understands. So and I'm fairly certain that the interns got the cases because the attendings really wanted to do it. And if you have an intern there, you can pretty much do it because the intern just wants to pretend like they're doing it. It's just my personal opinion.
I hear what you're saying. Yeah, I definitely feel more comfortable with an open inguinal hernia repair than I do with a laparoscopic repair. And so maybe that's where I'm coming from.
For sure.
Yeah. Thanks for joining us for this first of a two-part series with Dr. Amy Vertrees about the topics of autonomy and all things rural surgery and join us next time so that we can talk about a topic I'm sure that you're going to be interested in, which is how, when, why on inguinal hernia. Thanks for joining this episode of the Rural American Surgeon Podcast.